Hello everyone, my name is Ryan Kleichman and I am very grateful to have the opportunity to present our research and data to you today. My project is entitled Opioid Use Disorder and the Effect of an Inpatient Opioid Recovery Service on Patient-Directed Discharge, a retrospective cohort study. At our institution, we have a large number of patients admitted with opioid use disorder, and many of these patients receive an opioid recovery service, or ORS, consult. Let me define our ORS. It is comprised of people with lived experiences of opioid use disorder, or OUD, who provide support and guidance and can help patients navigate barriers to OUD treatment. An ORS does not have the ability to prescribe medications or give pharmacologic recommendations to the primary team. The results of our first aim, which were slightly surprising to us, showed that patients who received an ORS consult were actually twice as likely to leave as a patient-directed discharge, or PDD, than those who didn't. The details are in Table 1. There are possible explanations that may have contributed to this. Patients who actually get an ORS consult may be more likely to be experiencing acute withdrawal and therefore already have a higher propensity to leave as a PDD. The patients with OUD who are stable in recovery or in remission may not be getting an ORS consult while hospitalized. Patients in acute withdrawal need the symptoms treated and will tend to leave if the symptoms are not managed. Therefore, a service that provides pharmacologic management to treat the withdrawal symptoms may improve the PDD rates. Stigma towards patients with OUD continues to be a hindrance to treatment and follow through with care. This stigma is perceived by patients with OUD and has been cited as factors in PDD. This data can be used to help promote educational programs that introduce education and promote understanding for OUD in nursing and medical student training. Education about pharmacologic interventions can promote the use of timely, evidence-based interventions to control withdrawal symptoms. While our findings of higher rates of PDD in those who received an ORS consult are not consistent with published data, it needs to be clarified that the published data studied addiction medicine consults comprised of trained providers and not an ORS consult alone. This supports our hypothesis that PDD rates will be higher if withdrawal symptoms are not treated. We at our institution have now implemented an addiction medicine service and look forward to reassessing this data in the future. The results of our second aim showed that the rates of an ORS consult were equal across all races and ethnicities, detailed in Table 2. Our data also demonstrated that Black patients with or without an ORS consult had a lower rate of PDD when compared to white people. We were encouraged that the rates of receiving an ORS consult were consistent between different races and ethnicities, suggesting that our institution's current health equity training is effective and should continue to be prioritized. Our study was a retrospective cohort study and therefore has the known limitations associated with this type of research, most notably the inability to control confounding factors. However, our interesting baseline results have prompted additional questions for future research. I would like to thank Dr. Moore, Dr. Ryan, and Dr. Green for all of their guidance, support, and assistance with this project. Thank you.